imbalances. There are some issues with blood glucose monitoring. If they are hyperglycemic, you can use the insulin drip, and that works pretty good. We don't have to be very tight on the glucose control. 140 to 180 is a decent target to achieve in these patients. Evidence, there are multiple trials I have mentioned here. The most appropriate patient is a VFib arrest or the pulseless VTAC. However, 2010 ACLS guidelines recommended to do hypothermia on all cardiac arrest patients, and now in 2015 they have again recommended hypothermia on all patients with cardiac arrest who had a run of spontaneous circulation. Quickly, at our center, we started that program in 2013, and there are challenges we had to face, including the staff training. It should be 1:1 in ICU. It will be cruel for the nurse if you give more patients, including a hypothermia patient. Equipment buying, not very expensive, but you have to talk to your administration. ER participation and cath lab participation are challenges that you have to overcome. They will try to say no, but you can convince them with the data. So that's my presentation. Any questions with this?
Yeah, can we do hypothermia, or should we do a hypothermia protocol in patients who after cardiac arrest are not intubated and not on ventilator?
Absolutely no. The patient has to be intubated. Okay, so the cardiac arrest patient who is not intubated, meaning he's awake and he's breathing on his own and he's talking, which is a contraindication for hypothermia.
So not all cardiac arrest patients should be going hypothermia?
Yes, absolutely. Not all cardiac arrest patients who do not qualify the inclusion criteria. Yes. Yes, sir.
I have a comment and a question. The comment is you said about the when we say infusion in the patient and concern about the congestive heart failure. Personally, if we're trying to protect the brain, if the patient is going into mild congestive heart failure and we need to reduce the temperature, I don't mind. I give the fluid because the patient is intubated, ear is protected, we can deal with congestive heart failure, and those is protect the brain. That's the comment. Question I have is, if you see a lot of recent data suggests normal pain instead of 30 to 34, a lot of recent data suggesting 35 is a better option, and a lot of hospitals, including myself, is going towards maintaining a 35 instead of 30 to 34.
So it's not 35, it is 36. In that I mentioned, it is called targeted temperature management. For the patient who do not have EEG changes, who do not have cerebral edema on the CT scan, and who are following some commands, so they would benefit 36 degrees Celsius. But if they fall in otherwise category, there is tons of data that they will benefit from 32 to 34. Actually, the target temperature is 33, which they have studied. But 33, you cannot give a number. So that's why they came in with 32 to 34 degrees Celsius. All right, thank you.